Vascular Disease Management spoke with Frank Arko, MD, Chief of Vascular and Endovascular Surgery at Sanger Heart and Vascular Institute, Atrium Health in Charlotte, North Carolina, to discuss his experience with IVL for transfemoral EVAR and TEVAR access.
My algorithm for calcified vessels for large bore access in these two categories is really specific to sort of circumferential calcium and then the luminal diameter. So for most of these things, we need probably somewhere in the range of 6, 7, 8 millimeters in diameter. So if I've got a heavily calcified vessel and I don't have that luminal gain, then I'm going to go to the use of IVL to try to, one, break the calcium and maximize my luminal gain to deliver the system. Well, we've had a very good experience with IVL to date. This talk has really been a little bit more specific about EVAR and TEVAR, and we've had excellent results with that, and the data would really support that. And we do have data with regards to this technology. So the last one that was done was the Disrupt PAD3. This was a randomized controlled trial. You can really sort of see down at the bottom what was involved in this patient population. It was 45 global sites. Again, it was a single blinded randomized controlled trial, a total of 306 SFA and popliteal lesions, severe calcification, 83% of these patients, and the lesion length itself was almost 13 centimeters. The procedural success in the 30-day follow-up was presented at VIVA in 2020, and you had the 1-year primary patency and 2-year follow-up recently presented at SCAI in 2022. And again, take a look at this as roughly 153 patients in the PTA group and 153 patients in the IVL group. And when you take a look at this, what you really see is you get very nice superior prep, and you really get a very nice change in the compliance of that vessel. And it's an atraumatic sort of compliance change that you see. So one, you change that pressure at a much lower atmosphere, basically down to 44%. And you can also see here that the risk of dissections is significantly less, and that drops down by 77%. So really 3.5% versus 15.1%. Now, when you look at this and you take a look at what IVL does, again, it maintains the control of the procedure by minimizing the complications. And these are complications that all of us want to try to avoid. We want to try to avoid them both acutely as well as chronically, because acutely, we can usually fix it, but if you've got dissections, I think the long-term patencies of the interventions that we get are not going to be as great. And certainly the risk of embolizations and perforations, one, oftentimes is either a prolonged balloon inflation versus a covered stent that we may not want to do. And if you have to go chasing embolizations, that just becomes a very difficult thing for the procedure. So again, we know here that IVL will reduce that risk of dissections. It's statistically significant, drops it down 77%. Risk of complications in this trial, very low for IVL, 0% risk of embolization, perforations, thrombus, and no flow. And then the need for bailout stenting was significantly less. So the need for bailout stenting was down to 4.6%. And if we can avoid those scaffolding in these patients, I think long-term we don't have to then deal with the risk of stent fractures and things like that. And also, you just take a look at the long-term results. Now, most of these issues that you see here in the very early phase, where there's a pretty rapid drop-off between PTA and DCB versus IVL and DCB. But the difference in that curve sort of maintains out to that total of 2 years. And you can see here, it's great at 1 year. You can see a difference. You got 80% versus 71%, but that really maintains out to 2 years. We're still at 75% versus the 57% for the PTA and DCB versus IVL and DCB. Now, even more important, again, because we're talking about EVAR and TEVAR and large bore vessels, there was an observational study post Disrupt 3 that really had about another 1,000 patients in it. So if you, or excuse me, 750 patients. So if you take a look at the Disrupt 3 observational study, they had 752 patients. That was inclusive of a variety of different vascular beds, iliac all the way to below knee. You take a look at that whole group, risk of complications quite low. Dissection 0.9%, perforation 0.1%, embolization still low, 0%. We're talking about heavily calcified vessels. If you sub-select out the iliacs alone, you can see that the results maintain and maybe are even a little bit better. So that risk of dissection back down to 0%, risk of perforation in the large bore vessel 0%, and the risk of embolization is also 0. And you can see really just how nicely you modify that plaque. So in things that had diameter stenosis ranging up to 80%, when you drop that down, and this is in the whole group, right? So the entire vascular beds. When you use IVL, you really drop that degree of narrowing down to, around 30%. You do some adjunctive procedures, and then you can really reduce that diameter stenosis to in that range of 20%. When you really take a look at, again, what we're talking about in the EVAR, TEVAR, and the iliacs, you can see here again, very nice modification of those vessels, not much in the need for any sort of secondary adjunctive procedures. But when you do add those, that risk of stenosis drops down to 20%, just like you saw in the host groups. So next we will have a case of where we used IVL to stay transfemoral for EVAR and TEVAR access. So taking a look at the data that we just looked at, you can sort of see we feel very comfortable with utilizing this. And the concern that you get when you're doing large bore vessel and you're putting up very large sheaths is there's clearly going to be a risk of rupture in these cases. So especially as they get older. So here's a 79-year-old gentleman. It's got large aneurysms and heavily calcified. It's got calcified iliacs on the right and the left side. It doesn't have, the problem here is not really the common iliacs per se, but it's really going to be more so in the external iliacs. So when I take a look at these vessels, one, they can be calcified, which you can oftentimes get over and through. But if they're calcified and tortuous, that becomes a much more difficult sort of situation to have to manage. This is a patient who's overall quite has many comorbid conditions. Most of all, his ejection fraction is down to 35%. He's got acute kidney injury secondary to contrast in the past. He's got a defibrillator in place as well, and you can sort of see. And my concern here is if I rupture him, he doesn't have much in the way of being able to fix anything because his aneurysm comes down all the way down to both the right and the left iliac bifurcations. So if you rupture that and you have to sew a conduit on, you really don't have a safe place to one, clamp and sew on the conduit and or recover. So you're really looking at either an endoconduit or a conversion to major open surgery, which in this patient we really want to try to avoid. And here you can sort of see the axis, and you take a look at that arteriogram, you take a look at the IVUS. The IVUS is of the normal vessel, so it's what you sort of feel you can safely dilate up to. But if you take a look at that arteriogram and you take a look at that bifurcation, one, you actually see the internal iliac artery is out and the external is heavily calcified, quite narrow. And what you don't really see right there is just how deep it dives down into the pelvis. Now, he also has some common common femoral artery disease, for which we're going to fix surgically for that. But we were able to find a nice soft place to get access and then to proceed with the devices going up through those vessels. First thing we're going to do here is basically go after that severely diseased external iliac. I don't have to do much in the way of the common iliac because it's just large, it's full of thrombus and not that heavily calcified. You can see that the internal is out, but the internal actually fills quite well via the collateral that's coming off just below the inguinal ligament. So following shockwave, and for this we use the M5 Plus, which goes up to 8 millimeters in diameter. it's low pressure to break up the calcium, and the risk of dissection is low. Now, this one's aneurysm extends all the way down to the iliac. So some people say, well, after shockwave, do you have to stent the external iliac artery? I tend to be fairly proactive in stenting them because I just hate to have limbs go down. And, but in this case, I was going to stent because I had to extend that stent graft all the way down into the external iliac artery, and it's going to be extended with a covered stent. This one we deployed actually under complete IVUS control. You'll sort of see here that with this, I'm not going to feel real comfortable extending that endurant limb all the way down. The endurance is really more for aneurysmal disease. And when I extend down that extra, I'm probably going to switch off, and I did switch off to combining components in this case because I thought it was going to be the best long-term solution for this patient. So I actually stented down with a Viabond down in the external, which if this wasn't aneurysmal disease and I was treating, would most likely be the stent that I would choose to begin with. Now you could say, well, do you need shockwave if you're going to just do balloon angioplasty and use a covered stent? And I think in this case, it's important to sort of use the shockwave, one, to sort of, again, prevent that risk of rupture. So you could say, well, what's the risk of rupture and bleeding if the internal iliac is already occluded? Well, let's not forget that we had this very large collateral, which is giving retrograde filling to that external. So if I shift that plaque and shift it over, there's a chance that I could get to that vessel and then have fairly significant bleeding that I can't control unless I want to shut off that large branch, which I don't. So I think in this case, the use of a covered stent as well as IVL is helpful to getting maximum expansion of the vessel and getting complete apposition of that stent to the vessel wall and really preventing any sort of elliptical deformation of the stent itself and or enfolding of the stent. So we had a very nice result with this. And that's the case that I wanted to present today.
Vascular Disease Management would like to thank Dr. Arko for speaking with us and Shockwave for supporting this interview.